So, sir will be talking on fluorescein angiography in posterior uveitis. When is it required and when not? And sir needs no introduction.
So, no introduction. Can you open?
Just wait. It's not coming on the screen.
Ah.
Yeah.
I'd like to thank Dr. Rima for giving me this opportunity and particularly asking me to talk on fundus fluorescent angiogram in posterior uveitis when it is required and when not. I started using fundus fluorescent angiogram way back in about 30 years or even 35 years, and that time serpiginous choroiditis was one of the most common indication for me, and Eales disease. Over the years, I learned a lot about fundus fluorescent angiogram in posterior uveitis. I'll just share my cases. This is my opinion. This is a 40-year-old man who had a painless, no pain, redness, gradual, no pain, redness, gradual dimness of vision for 3 months. Look at the fundus picture. Do you think it's choroiditis? And do you need a FFA? Of course, you need an FFA. Is it choroiditis? It's no. It's multiple leak CSR. And if you look at the picture, it's very difficult to tell looking at it. And fundus fluorescent angiogram gives the clue. To me, this is the most important indication for me for FFA in posterior uveitis because it's a diametrically opposite treatment you will be providing the patient. This is a patient came with a CNBM, suspected CNBM, with a scar over the macular area. What is the cause of the CNBM with apparently normal fundus otherwise? If you do a fundus fluorescent angiogram, you will see that punctate hyperfluorescence and suggestive of PIC. You may not do much in this case, but you can get a diagnosis of punctate inner choroidopathy. This is a case of retinal vasculitis. Do you need a FFA? Obviously, this patient will require intensive laboratory investigations to rule out TB, sarcoid, collagen disease. But do you need an FFA? Obviously, yes. The reason is that you can see that veno-venous shunt, occlusive retinal vasculitis, veno-venous shunt, capillary gauze capillary non-perfusion, microaneurysms, and this all indicates the possibility of a disease which you call Eales disease, now considered to be thought to be immunological reaction to the mycobacterium tuberculosis DNA. And this patient's treatment will be requiring corticosteroids and anti-tubercular medications to me. And you may miss this such a subtle neovascularization which can be picked up by fundus fluorescent angiogram, and cystoid macular edema that also can be picked up. This is a patient to 30-year-old man, gradual dimness of vision, MANTU positivity, and there is a choroiditis lesions over here. If you do a fundus fluorescent angiogram, you will see that typical ring of halo, ring of fire there around it, and is very typical of TB choroidal granuloma. Not that TB choroidal granuloma have other fluorescent angiogram pattern, but this is quite suggestive of. In case of sarcoidosis, you will be seeing an hypofluorescence and which become totally hyperfluorescent lesion. You don't see the ring of fire appearance in case of sarcoid granuloma. Is there another situations where you need a fundus fluorescent angiogram is that mutes, multiple evanescence syndrome. This is a 20-year-old female complained of sudden scotoma, flu-like fever 1 week back. But if you do a fundus fluorescent angiogram, you see around the fovea a wreath of hyperfluorescence. And of course, the ICG can show that hyposenescence lesion. So multiple events and white dot syndrome is the diagnosis. Fundus picture may not show these subtle spots, white dot syndromes. In a case of SLE, fundus fluorescent angiogram is required. It gives a area of capillary non-perfusion and amount of capillary non-perfusion as seen in this picture. And here is you can see the retinal vasculitis with gross capillary non-perfusion in the case of SLE. 3 months after treatment with immunosuppressive agents, there is a complete resolution of inflammation. And this is the patient. After that, we did the aggressive laser photocoagulation and could preserve the vision. And this is another situations where elegantly fundus fluorescent angiogram can show this is a IRBAN, that idiopathic retinal arteritis, vasculitis, and neuroretinitis, aneurysm and neuroretinitis. And you can see the beading of the blood vessels, which elegantly shown by the fluorescent angiogram. And this is that this is the fundus fluorescent angiogram. Sorry, this is the fundus fluorescent angiogram. I will be showing in a case of VKH, sensory retinal detachment, in that one in both the eyes. Fundus fluorescent angiogram showed punctate pinpoint leaks, study skies pattern, and pulling of the dye in the left phase. This is in the other eye, has got symmetrical picture. Early is a multiple pinpoint leak mid late pulling of the dye. Of course, Webster's society has now come and has been aided in the diagnosis. This is a case of Base's disease, where you can see the gross capillary non-perfusion, capillary farning over their lesions, and this is quite suggestive of Base's disease. In case of serpiginous choroiditis in active and inactive age, the active serpiginous choroiditis would be showing hyperfluorescent border, and the central area with the hyperfluorescence. Of course, autofluorescence can be useful to monitor the disease process. FFA can identify the several complications, like here is a CNVM. This I have taken long time back, about 20 years back. I take the photograph, and that time OCT was not there. Fundus fluorescent angiogram, lacy hyperfluorescence was seen. In case of cystoid macular edema, OCT is better, but to monitor the disease process, but fundus fluorescent angiogram can show petaloid hyperfluorescence. In summary, for diagnosis like mutes, APM-PPE, we can use that FFA. To determine the extent of choroidal involvement, ICG is better, but fluorescence can show the lesion. To follow the disease process and to identify the complications like CNVM as well as cystoid macular edema. This is in short FFA indications and relative position in now in our armamentarium. Thank you.